Gastric sleeve is an operation where we resect about 80% of the stomach. We leave a long tubular stomach that has the capacity of about 80 to 120 cc's of liquid, which is very small. It's probably close to about the size that you could fit in your mouth right now. So it's pretty easy to overfill it. The greater curvature of the stomach and all the stomach associated with it is resected. And when we actually resect that part of the stomach, it allows the patient to be full and feel full with small amounts of food. And interestingly, the hormone ghrelin is produced, the majority of it's produced in the part of the stomach that we resect. And this is a hormone that is responsible for hunger and things of that nature, so it allows you to feel full early, maybe not be as hungry when dinner time comes around, so you eat less. Gastric sleeve is actually part of another operation. It was called the duodenal switch, and the duodenal switch is a complicated operation that has a fair amount of risk associated with it. What we found is in high-risk patients, the complications were pretty high, so we started doing the operation as a two-stage procedure. The first stage was a gastric sleeve. And what we found in these very high weight patients and these very high risk patients, they lost a fair amount of weight. We began thinking, well, if it's good enough for our high risk patients, maybe as a single stage procedure it's good enough for our low risk patients. And that's exactly what we found out. The weight loss with this operation equals a gastric bypass at 2 and 3 years after surgery. I think anyone looking for surgery to help control their morbid obesity and their weight problem, I think they should certainly give this some strong consideration. The operation may be indicated for patients who maybe would not like to have an implant in them, or maybe somebody who was concerned about the intestinal complications of a bypass, such as anemia, vitamin and mineral deficiencies on rare occasions, internal hernias, strictures, gastric ulcers. These are complications that we really don't see that much of or any of in a sleeve. So the consequences of some of the other surgeries that we do aren't quite as readily apparent with this operation. So when you talk about who's an ideal patient, I think it could be any patient considering surgical intervention. The gastric sleeve compares to the gastric bypass very favorably. It has a weight loss profile that's very similar to a gastric bypass at 2 and 3 years. It has a complication rate that is less. Some of the things we see with the gastric bypass complications like ulcers, strictures, anemia, iron deficiency, vitamin and mineral deficiency, we don't see with a gastric sleeve. But we don't have long-term data on a gastric sleeve either. But one of the interesting things about a gastric sleeve is if you do have failed weight loss, and failed weight loss is possible with any of the surgeries we do, and about a 5 to 10% chance of that happening, we have somewhere to go after a gastric sleeve. You could be converted to a duodenal switch, or you could go ahead and have a gastric bypass at that time and have continued weight loss. The differences in risk between a gastric bypass and a gastric sleeve is that mostly in a gastric sleeve you're not going to have ulcers, you're not going to have an increased risk of ulcers, strictures, intestinal complications like anemia, vitamin and mineral deficiency, internal hernias. Those things are things that you would not see with a gastric sleeve. To do a gastric sleeve, it takes us about 20 to 30 minutes to do. To do a gastric bypass, it takes us between an hour and an hour and a half to do normally. So it's a much quicker operation, and because it's quicker, you have less risk of a pulmonary embolus. Longer operations for morbidly obese patients tend to have a higher risk of pulmonary embolism, so we see a little lower risk with that. Patients may want to consider a gastric sleeve over other weight loss operations or options because sleeve patients may not have associated with them the intestinal complications of a gastric bypass, or they may not have the implant associated with a lap band. And those two issues may be very desirable for some patients. Patients that are extremely high risk may want to have this, as this procedure was pretty much invented for high risk patients. patients that do not want to have to alter absorption or distribution of medications that they're taking, like heart medicines or transplant medications, even some psychiatric medicines, that their doses are where they want. They may not want to subject themselves to another operation that could limit or could interact with the absorption of the doses of the medications that they're taking. So those are some pretty good reasons why patients would want to choose this operation over another.